Hello, this is Brent Thoma from BoringEM, and welcome to my first ever Chalk Talk. Today I'm going to discuss acute pain control. As noted in the title, this talk is intentionally basic. It will not go into the subtleties of this topic because it is directed at preclinical students interested in contextualizing their learning. For more information, check out the Chalk Talks page on boringem.org. To start off, I'd like you to imagine yourself in the ED during your first month of clerkship. A 47-year-old male named Jim presents looking extremely uncomfortable. He is writhing in pain, and his wife notes that he has no medical history except for kidney stones. He states that this pain feels exactly like his previous episodes. His vital signs are normal except for a slightly elevated blood pressure. Your attending asks you how you would like to treat his pain. By the end of this Chalk Talk, you will be able to discuss the common medications that are likely to play a role in treating patients with acute pain. At the end, I will describe how I would treat Jim. I divide acute pain medications into opioids and non-opioids. We'll talk about opioids first. Opioids are usually given intravenously or orally, and morphine is the most common one used in the hospital. While acute pain treatment guidelines call for doses of approximately 0.1 milligram per kilogram, the most frequently given dose is probably 2 to 5 milligrams. It can be titrated by giving additional doses, but keep in mind that the onset is about 20 minutes and will last for 3 to 4 hours. Sometimes we need to treat pain faster than morphine can work. That's where fentanyl comes in. It is a very strong synthetic with an onset of 3 to 5 minutes that will last about 30 minutes. It can be dosed at approximately 1 microgram per kilogram. Oral opioids are used for patients presenting with acute pain after you've got a little bit better control. Hydromorphone and oxycodone are often used for this purpose. We don't use morphine very much because it undergoes extensive first-pass metabolism by the liver. Hydromorphone is most commonly prescribed as 2 milligram immediate release tablets, while oxycodone is frequently prescribed in a combination pill with a non-opioid. The medical students I teach are often concerned about overdosing their simulated patients and have asked me what the maximum dose is. Opioids are interesting because there really isn't a maximum dose in the context of acute pain because you treat until the pain is tolerable while avoiding acute side effects like respiratory depression, hypotension, and altered mental status. That said, it's often wise to go a bit slower with very sick, very elderly, and those with liver or kidney failure because they will often be more sensitive. It's also good to keep in mind that there is a reversal agent called naloxone. While opioids are great medications for acute pain, because of their acute and chronic side effects, we like to minimize the amount that patients use. This is where non-opioid medications like NSAIDS and Acetaminophen come in. NSAIDS, or non-steroidal anti-inflammatory drugs, also have IV and oral options. Ketorolac is given IV at a dose of 10 to 30 milligrams, although the literature suggests that its analgesic effects hit a ceiling for non-inflammatory conditions at about 10 milligrams. Common oral NSAIDs include ibuprofen and naproxen. Contrary to popular belief, there really does not seem to be any difference between the efficacy of NSAIDs at equivalent doses. However, naproxen does have the advantage of twice daily dosing, while ibuprofen may need to be taken 4 times a day. Regardless of the route, NSAIDs should generally not be used in patients with renal insufficiency or a history of ulcers. Acetaminophen is another stellar non-opioid medication. 650 to 975 milligrams can be given up to 4 times a day, but it should generally be avoided in patients with liver failure or alcoholism. Now, back to Jim. During his stay in the emergency department, it was confirmed that he had a 3mm stone in his ureter with no evidence of hydronephrosis. My treatment strategy was to provide good pain control and get him home to wait until the stone passes on its own. After obtaining a brief history and vital signs, I ordered 100 micrograms of fentanyl and 10 milligrams of Toradol IV. As his investigations were conducted, he was given small 2 to 4 milligram doses of morphine every 15 to 30 minutes as needed to control the pain. At discharge, he was prescribed a 3-day course of hydromorphone and naproxen, along with some detailed follow-up instructions. I hope the intended audience found this quick overview helpful. Because it was my first Chalk Talk, and I hope to continually improve them, I'd appreciate if you could leave feedback in the comments. Do you prefer audio or video? If you prefer video, was the Prezi okay? Or would you rather I write it out like I would on a real blackboard?